Thank you, Mr. Chairman. Thank you to CROMA Pharma to invite me for discussing with you about an adhesive story. That means come back to the surface of the eye. And at first we go to the disease, not for surgery, but before or after anyway. And what is really a dry eye syndrome? It's a multifactorial disease, including the tears and the ocular surface also, and that results in symptoms of discomfort, visual disturbance also, it's so important for our patients, and of course tear film instability with potential damage to the ocular surface. The key words are also osmolarity, higher osmolarity, and you will see with me inflammation of this surface. It's a typical clinical aspect, but everybody knows that in the room. So after the syndrome, the anatomical aspect, that means what is the ocular surface also. It's a very classical view of this ocular surface and probably a little bit old view. That means the three separate layers we know very well. Separate layer by mucin, aqueous, and of course lipid directly down by the meibomian glands on the eyelids. But in fact, we know now that probably it's not as simple as you can see here, but probably just like this one. That means that you, in fact, have not three layers, but two separate. First one of lipid layer, that's right, but in fact the aqueous and mucin one are in the same, with a mixture of lacrimal fluid and the mucins, and which is very important, is that this layer is so close to the apical pole of the epithelial cells of the cornea. Why? Because there's a junction between the tear film and also the cells. That means, in fact, we can say that the tear film is the third tissue of the ocular surface. That means the cornea, conjunctiva, for the epithelium, of course, and tear film also. So what are mucins? Mucins are the largest and most highly glycosylated glycoproteins known. And not only, of course, on the eyes, but everywhere on the mucous membrana in the body. Epithelial mucins can be divided in several classes, and which are concerned for the eye are the cell surface associated. 11 are actually known, and also the secreted ones divided in soluble one, and the gel-forming muc-faviaceae. It's probably the most important in the surface of the eye, and that's what we are going to study now. Look at the structure and biochemistry, and for the gel forming of the muc-faviaceae, you need some domains which are needs to realize a polymerization, and at that moment, viscous formation of gel, which is quite different from the soluble forms and the membrane associated also. And here it's biopsy of human conjunctiva. It's in fact the factory of the mucins included in the goblet cells, periodic acid shift positive here. And on this new slide, you could analyze the surface of the conjunctiva examined with in-person cytology and marked with immunofluorescence using the muc-faviaceae antibodies. And you can see on the left side of the slide a surface of a normal subject. That means the red points are all the nuclei of the epithelial cells, and the green patches are the production of mucin marked by muc-faviaceae. If you could say that it's a normal one, here, of course, there's a dramatic decrease of the goblet cells population. But what is interesting, it's on the right part of the slide, you could put what you want as a patient. That means, of course, a dry eye patient, but also a chronic allergic could give the same thing, a contact lens wearer also, a glaucomatous patient treated for a long time with eye drops. Every chronic aggression of the surface gives the same realization. That's also the reason why in our clinical practice we all have the same problem. That means we do not have any specific symptoms given by our patients in all the problem of ocular surface diseases. Here, the same population of goblet cells, you could find the secreted mucus outside the cells, and you know that, for example, you have nervous termination in the cells. That in fact, when you have an acute aggression, then you could have liberation of mucin immediately. And I told you before, dry eye is also an inflammatory disease. Inflammation is a key point of dry eye. Briefly, on a normal surface, you have an androgenic impregnations and then a quiet situation between antigen-presenting cells and the population of T lymphocyte. But in the situation of dry eye, with the privation of androgenic situation, then you have a change, not only on the surface but also in the lacrimal gland, and a dysregulation of the antigen-presenting cells. And unfortunately, it's going up for the effector T lymphocytes, and then it's the beginning of inflammation. And as you could know, you could find it if you are checking the populations of the conjunctiva. It's also a conjunctiva impression cytology technique using an antibody, an inflammatory markers, in fact. It's an antibody directed against Achilla deer, and all the cells are positively marked in the case of keratoconjunctivitis. It's not the case in the normal patient with only dendritic cells marked positively by this marker. And I studied several years ago the relationship between mucin production and the inflammation. For this kind of studies, we used patients wearing contact lenses, soft contact lenses, of course. And there was two profiles of patients. One profile with soft contact lenses with higher level of inflammation in the conjunctiva. This study was before the time of silicohydrogel, I precise for you. And when you have upper level of inflammation, you have very low production of mucus. And it's exactly the inverse correlation with rigid contact lens. That means that you have poor level of inflammation and a good production of mucin. And that's what's the reason why we have, as a mechanism of dry eye, this vicious circle very well known now. It's from the last dry eye workshop in 2007, published in Ocular Surface Journal. And you have the problem of goblet cells with loss of glycocalyx mucin, and then instability, osmolarity, and inflammation. That's a mechanism. As a clinician, you know that our clinical tests are so poor. Of course, you could realize the breakup time with the fluorescein. And if you want more specific information, you could use lissamine green staining that's stain only the part of the conjunctiva with mucin deficiency. But in fact, nobody do it in routine practice. That's right. So what we need as a mucoadhesive properties of an ideal substitute, we need these properties of mucoadhesion as the natural mucin, that means the secreted one, the gel-forming one, mentioned before with muc-FAVC. And there's a THIOMER technology could mimic, probably with the covalent bonds. And we need a substitute which be able to be bind to the natural staining mucin. And this THIOMER technology is very interesting, according to me, because they can mimic the properties of the mucin to be linked each other. It's also the same properties for the polymer in itself, but also both. That means with the natural one and the given one also. And what we could expect, probably for our tear film, is to be able to reproduce the original aspect of our very complicated tear film, in fact, with the aqueous mucus layer and after probably the lipid one after. And with a very high time of duration upon the cornea, which is particularly difficult to have, actually. Okay. That's the last one. Thank you very much.
Thank you very much. Are there any questions from the audience? If not, I have a question. You talked about and showed also data about the reduction in mucin production, for instance, in long-term contact lens wearers or in patients, in glaucoma patients that have a long history of topical anti-glaucoma medication. To which degree and to which point is this reversible? For instance, if a glaucoma patient undergoes trabeculectomy, let's say after 10 years, and then requires no additional medication, does the mucin production come back at some point?
Yes, it's a very important point that you precise. And the answer is not so simple. But, the previous studies were done in England by the team in the Moorfield, I think. And it was the time with all the antiglaucomatous medication were available, included preservatives. That means benzalkonium chloride, for example. And at that time, the period of reversibility was about 3 years. But actually, it's quite different because we know that we have several kinds of family, 2 kinds of family, with or without preservatives. And it probably changed in the good way. It changed the sense of this time. But it's a key point, sure.
Are there any further questions? Yes. Could we have a microphone, please, in the back there?
Thank you. I would like to ask if the lacrimal plugs sparing the tear film will be the solution to contact lens wearers and people using anti-glaucomatous treatment.
It's a solution, of course, but with using of plugs, you keep on the surface 2 things. Maybe aqueous, if some aqueous stay, yeah. And also all the inflammatory mediators that are produced by the conjunctiva. So according to me, it's not the best solution for clinical quiet aspect of the surface. But it could be.
What is the solution you are seeing better than?
For the contact lens wearer?
Yeah.
Refractive surgery, for example.
No. No. I mean, and it's not also only the contact lens wearers. Maybe people living in areas where the environmental conditions are very high temperature, some pollution.
I don't know, in fact, but the 2 key points I can tell you, it's at first using disposable contact lens without any solutions, if possible.
Yeah. The they use, you mean the?
Yes, the they do. And or maybe better for the surface is also the rigid contact lenses. I know, but
yeah. Okay, but I think that also with the LASIK and the refractive correction of the cornea, there is some dryness resulting from the surgery itself. So they need also to have some solution. Not the local. Not the local drops, which are just moisturizing the eye, but I think they need something, as you said, with the components of the normal tears protecting the eye.
I have no other solution.
Okay. Okay, thank you.
Unfortunately, I do not know any.